Hi, welcome to today's community chat. We're going to be speaking about the new proposed guidelines for breast cancer screenings. We have Sentara Radiologist Dr. John Plemmons on with us, and we're sort of just going to go through what those guidelines are and ask about early testing and screenings and what that means and what people in the community should know. So, Dr. Plemmons, thank you so much for joining us today and taking time to, maybe break down, what these new guidelines are for people to understand and also just go through, what the new suggestions mean. So, would you
Yeah.
mind just, starting by telling us a little bit about your own practice, what kind of screenings you do? I'm sure there's a variety of different things that you touch on besides breast cancer.
Well, certainly my focus is breast cancer, and yeah, I support. I'm the medical director of the McCluskey Breast Center at the Broad Cancer Institute, a Broad Cancer Center in Norfolk, Virginia. And most of my career, I've been involved with breast cancer detection and breast cancer consultation, basically working with our medical oncologist, our surgical oncologist, our pathologist to attempt to find breast cancer as early as possible and to collaborate with the area's experts to make sure that the patient gets the optimum care, the state-of-the-art care, and the best possible outcome. I've been in this practice in the area of breast cancer detection since about 2006. We focus on certainly screening mammography remains the most important tool, but we also deal with or work with ultrasound, MRI, and we've been involved with several national clinical trials, including the use of abbreviated breast MRI as a screening tool for women who have dense breast tissue. And we have been involved with other clinical trials and are currently involved with the multi-center national TMIS trial, which is looking at the use of 3D mammography and its advantages over other screening methods.
For women who have, dense breast cancer, breast tissue, or things like that, I mean, what types of exams do they need?
So certainly mammography, it remains the workhorse for all patient populations, and that includes women who have dense breast tissue. We know that approximately 45% of women, um, certainly if you look at our screening population over the age of 40, we're looking at about 45% of women who are going to have breast density, which is characterized as either heterogeneous or dense, more than 50% fibroglandular. And we know that mammography is not as effective in those women, and yet we also know that it is a excellent screening tool and remains the most tested and proven screening tool that we have. So where screening mammography may be good at picking up 95% of breast cancers in a woman who has relatively fatty breast tissue, the sensitivity, the ability to detect breast cancer is lower with women who have dense breast tissue. We estimate it to be around 65%. But 3D mammography has improved that significantly. Well, first of all, the advent of digital mammography was an improvement over standard screen film or film screen. And then we went to 3D mammography, which is yet another enhancement. And quite frankly, the technological improvements are happening at such a rate. Many of us are now using an advanced form of high resolution mammography called Quorum 3D. And although it hasn't been fully tested, my personal experience is it's even better at women with dense breast tissue. But other options would include ultrasound and MRI. There are other modalities out there that are being tested, including contrast enhanced mammography. That's not offered locally yet, but it is something we're looking at that is being studied nationally. And gamma imaging, not as a screening tool, but as a helpful diagnostic tool for women who have other breast symptoms. So there's a lot of modalities out there that we recognize, that we support, and that are being carefully studied.
sorry, you think you can all hear me now, but is 3D mammography something that is widely accessible throughout the country, or is that something that really is maybe perhaps only at more advanced centers?
At this point, when the FDA initially approved 3D mammography in 2011, and Sentara adopted it in 2013, and it became pretty much the standard relatively quickly. At this point, nearly 10 years after that, I think it's pretty much accessible throughout the country. It's difficult to imagine a place that is only offering 2D mammography, and it's even accessible in our 3D mobile van using state-of-the-art 3D hologic screening tools. So I think at this point, it's relatively accessible in just about every patient population or area of the country, I would think.
And, for people that don't know everything about this study, it is focusing on, people with the average risk. So it's, focusing on people who, perhaps don't have that family history or don't have that higher risk. I mean, can you speak a little bit about, that person of that population that is just average risk? They might not need something till 40, but that is something, right, that you all would say, speak with your doctor and know your, maybe genetic predisposition or something, because you might need screenings earlier than 40.
Yeah, you really just hit something that is so important. We're really trying to get additional information out at multiple levels that question touches. First of all, the ACR now, American College of Radiology, recommends that patients, every patient undergo a screening risk assessment at the age of 25. Your primary care doctor should be able to do that. Your OB-GYN should be willing to do that or able to do that. And quite frankly, any of our breast centers can do it. If you just walk in the door, we can connect you with some of our high-risk specialists just to sit down and quickly go over your risk factors, your genetic and other components that influence your risk for developing breast cancer. Because, and I know we do want to talk about the modified USPSTF guidelines, but really where I am interested, and a lot of radiologists are interested, is in that patient population who has an elevated risk of breast cancer, who may not know it. They come in at the age of 32, they have a palpable lump, it ends up being malignancy, and when you talk to that patient, you find that their mother had breast cancer at the age of 40, their sister had the breast cancer at the age of 35, and we should have been doing screening mammography on that patient or other screening exams at the age of 25, 10 years earlier. And yet, so that's an opportunity missed. And it's not just an opportunity missed because of the fact that the patient is mostly an educational component. We need to get that information out there. So your question focused on a couple of people. One, women who have dense breast tissue but are not at elevated risk of breast cancer. What can we do for them? And it's interesting that just recently reintroduced is the Find It Early Act. And the Find It Early Act is a bipartisan legislation which is now in Congress. I would certainly encourage people who hear this discussion to learn more about it, because what it is trying to do is to essentially legislate that insurance companies provide screening, pay for screening for women who have dense breast tissue, even if your risk is average, because of the reduced sensitivity of mammography. So if you're 45 years old and you have dense breast tissue and your insurance company doesn't cover supplemental ultrasound or MRI, that's a problem. Many of us offer some additional tools, but those, that's out-of-pocket expense. And for many, particularly some of our underserved communities, it's prohibitive. So the Find It Early Act, I think, offers some hope for patients who find themselves in that category. For women who have an elevated risk of breast cancer, well, things begin to open up a little bit, because now insurance companies do provide at least supplemental screening for many of those patients, of which we really lean on MRI. MRI would be the go-to for women who find themselves in that category. Yeah.
And, there is something in the study, I think the chair said, they are calling for more research to improve, and you sort of touched on this, some of the health inequities we face related to breast cancer.
Yeah.
So perhaps, access to screenings, and not to mention, there are certain groups of population, primarily, it says for Black women, they're 40% more likely to die of breast cancer than white women, and are likely to get deadlier cancers at a younger age. Like, that's a pretty
Yeah.
staggering, percentage difference.
Yeah, it is. And I've seen it too often in my own practice. And if you look at so the USPSTF in their draft statement, that is, that's received some attention, fortunately, went back to their recommendations for screening at the age of 40, something the American College of Radiology never veered from. We've maintained that 40 was the appropriate age to start screening. And when you look at their explanations as to why they went back to 40, they focused on the fact that they were concerned that some of the underserved patient populations, underinsured, young Black women in particular, who were coming up with these triple negative breast cancers, and that by the age of 50, it was too late. We were missing an opportunity to find those women. So absolutely, that helped drive their recommendations that we begin at the age of 40, just as the American College of Radiology recommends. I must take issue, however, with their recommendation that they get screened every other year. The American College of Radiology continues to recommend annual screening, and it's so important for women of that age group, Black women of the age of 40, who develop a triple negative breast cancer. If you're getting screening mammograms every other year, it won't be soon enough. This cancer can grow aggressively. It can come out of nowhere. And I've seen it way too often. So not only is annual mammography important for all women at the age of 40, but particularly for African American or Black women. It's not only key for them, but it's also so important that they recognize their family history, because many of them should be getting additional screening before the age of 40, and by the age of 25 or 30. So that's a patient population that we really have to try to get to better. We have Sentara, and I personally and others, my colleagues, have worked with some of the community groups to help access that community, but it really needs to be an all hands on deck effort. And I saw, as I was talking, you showed the mobile van again. That is, it's a wonderful tool for getting out to some of those underserved communities, not only in some of the poorer areas of Norfolk or Portsmouth or other surrounding Hampton Roads communities, including northeastern North Carolina, rural areas that may have limited access. This van can bring absolutely state-of-the-art mobile technology, 3D technology, essentially anywhere. And we've already had some anecdotal examples of women who had not been screened, but took advantage of the van being nearby, and they found a stage 1 cancer. So that's a life saved in essence. So yeah, absolutely. The key is to...
Oh, sorry, excuse me. The mobile van, that is something where I can include, information of that on wavy.com after, as well as the, Find Early Act, for people. I think people in the chat are already asking where the mobile van is, and, maybe where they can reach out for that resource, which is great.
Sure. We do have Sentara, and also they can, the Sentara website, there are community, so there's, right now, there are so many barriers to complete access and fair access to all of our patient population. And so it's not just patients for whom insurance doesn't cover adjuvant screening. We have patients who don't have insurance at all. And Sentara partners with many of our community fundraising, charity, many of the breast cancer and other types of cancer outreach efforts to help provide funding for those. So you can get plugged into that through our website, or just walk into one of our breast centers and we can get you information about that.
And, 1 year to 2 years, that can make a big difference. Like during COVID, I'm sure there were a lot of cases of women, who missed that slot, and then maybe did see something, on, either a mammogram or in some other capacity.
Yeah, you're exactly right. I mean, we what we witnessed was just a real bump in perhaps later stages. I don't have quantifiable data, but it is something that has been described in the literature at a national level. That 1 year dip, in essence, in screening created a surge of patients who were presenting, a little bit later, maybe late stage one, maybe stage two, or beyond. The good news is our medical oncology colleagues have really done a terrific job of treating this disease at just about all stages. It's not, so we're coming at this from all sides. The medical oncology team has medications that are effective in treating even triple negative, triple positive disease, all subtypes of breast cancer. And so the prognosis gets better for everyone, but we still want to catch it early. And the COVID shutdown definitely, we witnessed the results of that, definitely.
And in terms of radiation, I've seen in some places that there is this worry of having radiation when you don't
Yeah.
need it. But I mean, is that something that is quantifiable that you can see, what risk you have, or is that something where the risk for breast cancer is so high that the recommendation is really to make sure that you don't have breast cancer versus maybe an extra bit of radiation?
Yeah, we get this question quite a bit, and it certainly came up when we initially converted to 3D, because the initial 3D mammogram had twice the radiation dose of the standard two-dimensional mammogram. So there was a real issue then. I want to reassure all of the people listening that that is no longer the case at most breast centers, certainly all of the Sentara breast centers. We use synthetic 2D mammography. The software is good enough to generate a 2D model from the 3D data set. And so the radiation exposure is back to where it once used to be. And it's really so low. It's so very low. The technology is good enough now with very little radiation. We're able to get wonderful pictures through the breast tissue. And so people should remove that from their concerns. We've been doing mammography since the 80s, really since the 70s or even before, but really it became more of a national program that rolled out. And there's never been an example of radiation-induced breast cancer from screening studies. The radiation dose is trace. You get more from flying across the country, living a normal life. So I want to reassure people that that the radiation exposure for a standard 2D or 3D mammogram, as we do them now, is so low, it should not be an impediment.
And I did want to ask the messaging and guidance on what the U.S. Preventive Services Task Force say. I mean, how powerful, is that in the sense of the medical field compared to maybe the American College of Radiology? You all are saying, every year, starting at 40, and you said it hasn't wavered. So, for this to come out, I mean, is this affecting insurance? Is this affecting, maybe more of a universal idea of what, breast cancer screening should be? I mean, how powerful is this decision?
Boy, that's the $1 million question, isn't it? You really got to the meat of the matter. I will tell you that many of my primary care colleagues do take the USPSTF guidelines to heart, and did modify their screening recommendations for their patients when the initial recommendations from the USPSTF came out in 2009. And so even my own primary care doctor was saying, well, women aren't supposed to begin screening if they're ever. So we were hearing that, and these are, listen, although the American College of Radiology does not agree with their recommendations, we're grateful that they've recommended starting at 40 again. And these are well-intended people. They're looking at, they are trying to balance that difficult risk. We don't take this issue lightly. We're asking a woman who feels nothing, who feels completely fine, who has no symptoms whatsoever, to walk into a breast center and take the time from their schedule, the insurance issues, the discomfort of a mammogram to the extent that there is discomfort, perhaps go through a biopsy. We have to know that that it helps people, that ultimately we're doing good through this screening effort. And so they were looking carefully at the data, and they're looking at, they're trying to look at randomized, random trials to justify their recommendations. The problem is randomized trials, blinded randomized trials are expensive. They take very long to perform, and the technology is getting better and better all the time. And so it's difficult for them to look at that information and come to conclusions that really mirror what we see on the ground, the boots on the ground, those who are actually seeing patients. So I think the ACR has done a better job of staying focused on the fact that we know that we can save lives through early detection. Your question, do people follow the ACR guidelines? Certainly radiologists do. I think a lot of breast surgeons, our guidelines tend to mirror those of the American College of Surgery or Surgeons, as well as the group of breast surgeons and the Society of Breast Imaging. So we're on the same page. I'm hoping that the modification in the USPSTF guidelines will encourage other primary care doctors to have their patients screened at the age of 40. With respect to insurance, the insurance companies continue to reimburse for screening at the age of 40, which we're grateful for.
And, I do want to say that the task force study did talk about, how this could potentially save 19% of lives, that otherwise would not have had the breast cancer caught or something of that date, or maybe it diagnoses earlier on, so maybe it's more treatable. But there is something there. Mm-hmm.
Yeah, and I think, the one thing that they did highlight, they talked about in their summary statement, that there's insufficient data for a couple of patient populations, and it gets back to that randomized, double-blind randomized trial, clinical trial criteria, which is a reasonable criteria. It's just a tough criteria to meet in today's world. Who's going to pay for that? Are you willing to wait for 25 years for the results to come out? While women are dying. So we have to circle back and look at the historical data, the effects of mammography and studies that have been going on since the 70s, and we've seen the results. But certainly more research is indicated. That's always appropriate. Study the patient population and study the risks and benefits carefully all the time. The moment that I feel like screening mammography is not helping patients, I'll find something else to do and we'll stop doing it. But we just see the benefit, consistently every day.
And, with this lower age recommendation, are there resources available? You can perhaps only speak to Sentara, but, is there enough available, whether that's employees, whether that's centers, to sort of take on this extra need of maybe new patients that are coming in? How long does it take to do these exams or to read the data that's coming in?
So, it's an interesting, Sentara just went through a very detailed analysis of, is there capacity within this market for the patients that we should be serving? And the answer is perhaps still to come. There's certainly evidence that we have increased capacity within the system, the hardware and the system as it now stands, but we need to look into the future. I don't think there's adequate resources in the way of screening breast ultrasound to supplement women who have dense breast tissue and are concerned. There certainly is not adequate capacity in the world of breast MRI. So although we're pretty well positioned for screening mammography, although I think that, as I said, that continues to bear some looking into. For example, I wouldn't mind having a fleet of mobile vans out there, doing their job, because access to care remains an impediment to patients getting screened and having their cancer picked up. But so in terms of capacity, we're in pretty good shape for mammography. I think breast ultrasound, breast MRI, these are areas that may require some additional investment.
And, for some women, and I will say some people, and maybe COVID sort of spurred on this problem a little bit more, but, people don't visit their primary care doctors like they did, and everyone might not have an OBGYN that sort of covers more than just maybe the regimented exams. I mean, to those
Yes.
people who might not go to a primary care, might not get the recommendation that they are higher risk or average risk, or, is primary care so necessary in this department to be sent to radiology? I mean, are they the ones that really should be the keepers of how healthy you are, of what your risk is?
So let me say this, a careful clinical risk assessment is the standard, and your primary care doctor or your OB-GYN are really the place to start. Now, what you just described is something that that we recognize. I have been educated in, quite frankly, by some of our community liaisons, when I would say, we just need to have these young women speak to their primary care doctors. She would look at me and say, Dr. Plemmons, these women don't have physicians. They don't see doctors. Okay. You're not, you're not relating to that patient population. So the answer is, it certainly is the proper place to start. And I would encourage everyone to reach out if they don't have insurance, find, through the Sentara ACC clinic, or through the medical school, or through some of the public health departments, to try to attempt to make a connection with some type of primary provider. But if that's not possible, walk into a breast center and say, I'm concerned about my family risk or my genetic risk for breast cancer. And we can connect you with those who can help with that process. We do have a high risk clinic right now. And although I don't want to overwhelm them with people walking in the door, primary care remains the first tool and the first approach. And I would encourage everyone to secure some type of primary care provider. But I don't want there to be any impediment for someone who has a mother or sister with a first degree relative with breast or ovarian cancer in particular. Family history of breast or ovarian cancer, particularly before the age of 40 or 50, we're probably talking about you. And you probably need to, make any effort to get identified and the additional screening that you need. So I hope I've answered your question.
No, absolutely. Thank you. And I think, one of the last things I want to ask is, there's a comment period, open till June 5th.
Yeah.
And that we'll see what happens with the guidelines, after that period's done. But you said that, the last recommendation was 2016, and, we'll see what updates, I guess, there are for maybe a next update if there's nothing new to come this year. But I mean, is there anything that you're hearing or, that could potentially sort of change these guidelines in the next month? Or is that something that, just more research is hopefully coming down the line to maybe, change what they recommend?
Yeah, I mean, certainly, I think most of the American College of Radiology is expressing to them during this draft period, this comment period, their concern that they recognize the need for early screening in women who have dense breast tissue or who have an elevated risk of breast cancer, the importance of that screening, but that it's not consistent with the every other year recommendation. It sort of defeats that purpose. And so we're trying to articulate that point. But nothing I'm hearing suggests there's going to be material changes in the draft statement. Right now, I do think there's going to be a continued research in this. As I mentioned, contrast enhanced mammography. This is an area of real interest to me, as I've seen some of my colleagues in different parts of the country using it as a replacement for MRI. It's better tolerated. And it sort of sees through the dense breast tissue. So there's a lot of research being done in a lot of areas, but no, I don't expect material. I've not heard anything to suggest there'll be material changes to the draft statement as it now is written.
And I think, I think we covered a lot of it. We talked about accessibility. We talked about, some of the issues that are still needing to be resolved. But, is there anything else that we did not touch that you feel like is critical, or do you think that's, very relevant to these new guidelines?
No, I would just, I would say maybe three things. First of all, I have had women come to me or come in with an advanced breast cancer at the age of 48, and I say, why didn't you get a screening mammogram? And they say, well, I didn't feel a lump until now. And so I want to just pause and, because I think sometimes medical professionals understand the terminology, but I'm not sure the terminology is universally understood by all. The purpose of a screening mammogram is to detect breast cancer, to find breast cancer before you feel anything. You feel completely fine. So I want that message to be permeated. At the age of 40, get a screening mammogram. You will feel no symptoms. You're the patient that we're trying to find that small breast cancer that has not shown itself in any other way. And then the other two things I was going to mention, your questions were quite thorough. I was going to encourage people to support the Find It Early Act and to write their congressperson, because I really think the supplemental screening methods is going to tackle that significant portion of our breast population that do have breast density and for whom mammography isn't a perfect tool. It's still a great tool, but it's not a perfect tool. And then I would encourage, as you had already mentioned, get your risk assessment by the age of 25. However that is done, through your primary care provider, through the health department, or through the breast center, let's get a risk assessment going so that if you need to be screened before the age of 40, we find you before it's too late.
Well, thank you, Dr. Plemmons. And I think, those things I will echo and add resource links for people to look further into the act, as well as, offer that guidance that you shared of getting that assessment by 25. So thank you so much for your time. I'm sure there's so much else we could have covered in this, and I know this is a very complex issue, but hopefully we gave, some information out there to people who are wondering what these guidelines meant.
Sara, I really appreciate your time and your interest in this. It's a very important message to get out to our community.
Absolutely. Well, thank you all for watching. There'll be more on WAVY.com later. And, please take a look at the resources provided that Dr. Plemmons spoke about, and we'll see you next time.
Very nice.